medical care shifts maternal mortality. All the other type of care is wonderful. Home health visitations are wonderful, especially in early childhood development. They can increase breastfeeding, they can reduce postpartum depression, but only medical care can reduce maternal mortality.
Welcome back to the Midwifery Wisdom Podcast. This week, co-host Augustine Colebrook is joined by none other than Sonal Patel. You might recognize her name if you attended our 2023 Denver Midwifery Wisdom Experience. She was our wonderful keynote speaker. Today on the podcast, her and Augustine are diving deep into maternal mortality, maternal care, women's health. Basically, just get ready to get pumped up to learn how changes are being made for how maternity care and women's health are treated in the United States. Sonal shares some shocking facts about maternal mortality. She shares some incredible things that her company is doing to normalize more than just the basics of postpartum care. In her own words, we focus on bringing medical care back to the house. Get ready to be excited for big changes being made in the medical system to align more fully with the midwifery model of care, and ultimately to create a happier and healthier pregnancy and postpartum experience. Let's dive into this mind-blowing conversation.
Sonal, yes, hello.
How are you?
How are you? I'm quite well, thank you. How are you, friend?
I'm doing good. I'm doing good.
It's good to see you again. Thanks so much for
Yes.
joining us on the podcast.
Yes. Oh no, thank you. When I saw that, I was like, oh, this would be awesome. So
It's so awesome.
that's great.
I'm glad you're here. Well,
Yeah.
so first of all, for listeners who don't know who you are, I'm going to give a
Uh-huh.
tiny rudimentary introduction, and then I want you to take it away, okay? So,
Sure.
first of all, is it Sonal or Sonal?
Sonal. It's like tonal with an
That's
S.
what I thought. Yeah.
Yeah.
Sonal. So Sonal is what we like to call the home visiting neonatologist. That's a really big deal. And
I didn't think of it that way.
I would love for you to expand that job title into more of what you do and who you are.
Okay. Sounds like a plan. So my name
Yeah,
is
we
Sonal
started.
Patel. And I am a pediatrician further trained in neonatology. I'm also a lactation specialist, and my pivoting and my big change in life came. I'm a mom of four, and that's just very important for the whole picture of it. And postpartum literally just killed me, and we can get into all of how that killed me. And I just saw my medical system failing me, and it was a very shocker because I've been trained as a pediatrician, as a neonatologist. You witness the postpartum period more hands-on and more upfront because you're not only dealing with premature babies but also their mothers. It really struck me that with all the knowledge that I had, if it could fail me, then literally what about the other mothers? And so I created a home health company about 5, 6 years ago now, and we really focus on the fourth trimester and bringing care, medical care, back to the house. And one of our biggest mission is also maternal mortality and reduction of it. And when we look at the data, that's what we see is that medical care shifts maternal mortality. All the other type of care is wonderful. Home health visitations are wonderful, especially in early childhood development. They can increase breastfeeding, they can reduce postpartum depression, but only medical care can reduce maternal mortality. And so that's what I do. So bringing moms back into the picture.
Well, yeah, right. I mean, centering that postpartum person for sure. Well, so I want to go a little deeper. I think many of our listeners will understand what you mean when you say maternal mortality in the fourth trimester and, clinical medical care postpartum and all those pieces. But there may be some folks who listen who are either students or parents or doulas or somewhere in that process. And I guess I would just love to ask you a couple follow-up questions to this crisis that you discovered kind of by accident. So first of all, how does the mainstream medical system fail new mothers?
Yes. So what it does is that during pregnancy, you have about 10 to 15 appointments for yourself. And we'll overlay that with the maternal mortality data because then it becomes more evident. Then thereafter, after you give birth, you have one postpartum visit at your 6-week mark. And we know from data, 40% of women do not go to their 6-week appointment. So you have this structure that is super heavy on pregnancy, but the minute that the baby is born, it's all shifted towards the newborn. So now if you look at the newborn aspect in that first 6 weeks, they have about 3 to 4 appointments given. It's just given that they will have that. And the shift of care becomes directly to the newborn. And all the mom does is lugging their babies around. Now, when we talk about maternal mortality and piecing that puzzle together, maternal mortality was defined by the WHO, the World Health Organization. It's any death, pregnancy related death, pregnancy, birth, and postpartum up to 42 days. And there's other terminology that comes along with it, but up to 42 days after the birth of that child or some sort of how the pregnancy ends. Unfortunately, we do have abortions and we do have miscarriages, and so those are accounted for as well. So when you look at that data, you notice that 1/3 of mothers are dying in pregnancy, but 2/3 are dying after birth. And when you look at the medical system, we're not supporting those mothers. Moreover, when we have the 6-week appointment, so 6 weeks aligns exactly with the 42 days, you have of those 2/3, you have about 50% of women that are dying from pregnancy and postpartum related complications during that period. And then on top of that, 40% of women don't go to their appointment. And we just skim over, we talk about maternal mortality because it is a crisis, and we'll get into that. However, we're really dismissing all the morbidities that we come with when pregnancy and all the education that happens there. We barely do a good job with maternal mortality that we don't even talk about the morbidities that come that women face, So I hope that clarified a little bit of adding
it's
the data.
So clear. And like I said, many of our listeners really get the clarity. That's why they're functioning outside the system. It's providing alternatives to that system. But I just wanted to make it really clear. And of course, we haven't really touched on this yet, but aside from like you said, the mortality issue and even the morbidities, the mental health is another huge component of this, of recovering from that crazy hormonal swish that happens at birth and the pressures and the weight that is on the new parents. And then, like you said, this societal outcome that could be interpreted. If you were the birthing person, you could definitely interpret oh, I'm just a vessel. I'm not the one that matters. It's definitely the baby that matters. And that's a really devastating message to receive in those first few early weeks and days. And that is definitely failing people for sure.
And then so midwives do.
Go ahead.
No, I'm just saying, but that message is being seeped throughout not only medical system, but our society and culture. I mean, we do baby showers, right? We do the minute that the baby is born, it's all about, oh, mom and baby are doing great. And then it's like people coming over to hold the baby, and it's all the tension is done too. And it's just not the medical system. I think we just have to have a huge shift.
It's really
culturally and it totally is. So
yeah. Well, I know that you know this. We had a great talk in Denver when you were there. Sonal was our keynote speaker in Denver this year. So that recording is accessible, which is really an awesome slideshow. But in Denver, we had this really quick conversation about how the mortality, the morbidity, the mental health, the hormone shifts, all these things happen. And it's like traditional midwifery throughout the ages kind of was attuned to this and knew this already, because it is absolutely, I think, true all over the world that postpartum women get extensive care by their midwives. And I find it so exciting that you are leading the charge towards essentially normalizing the postpartum period and bringing back what used to be and still is traditional and true for the midwifery communities. Have you faced any backlash? Like, are any of your colleagues like, what are you doing? Or is everyone supportive?
I live in Colorado, so I think the state in itself is quite progressive and quite, there's more options in birth here. Um, and it's kind of surprising that even with my own experiences, I didn't have and I wasn't even attuned to all the options of births that we have available in Colorado. So I think the landscape is a little bit different as compared to maybe other states. I mean, we have freestanding birthing centers, we have home births, we have your typical OBGYN providers. So I don't think there's been a true backlash per se because of the community that I practice within.
That's awesome. And you're trying, so let's tell me about this clinic. It's called Naya Care, right? And
Yes.
you have a number of team members. It's not just you anymore. So tell us, what does this structure look like?
Yeah, so it's really looking at the fourth trimester from the perspective of the mother slash the birthing person, because all of these things that we're imposing on them does not happen in a vacuum, right? Like we don't want to have breastfeeding success and what we do is all these outcomes like decreasing mental health, increasing breastfeeding rates. These are all super connected. It is not happening in a singular pathway. And some of this is, and so when you talk about mental health, I sit back because I actually had postpartum depression with one and anxiety with another. And the one I had, the depression one, was I actually had a grade 3 and a grade 4 tear. I physically could not get up. I physically could not do some stuff, but mentally, I had to push myself to get to my pediatric appointment because that's what I was told that I was supposed to do, right? And I think we undermine the actual, we say birth trauma, but I think it's truly, if you can look more deeper into it, it's this acknowledgement of physical recovery that we're not allowing our mothers to have and space to have it. So now I have a grade 3, grade 4, and 3 to 4 days after my leaving the hospital and getting into a car. I don't remember all the bumps and stuff. And then the next day going to my pediatric appointment and being asked, how are you doing when I can't even sit on that chair? Or, you have to allot, like an hour or two just to get to this 10-minute appointment where all they're doing is weighing the baby, making sure there's no jaundice issues, making sure the breastfeeding is going well. And then in our medical system currently, and I don't fault any of my fellow pediatricians because it is a medical system, it's the structure that we've created. Some of them just don't have time, right? Some of them don't have time for breastfeeding and all of that. So
system.
yeah.
It involves like insurance and reimbursers and payers, and there's so many limits that are externally enforced. And I think most doctors alive today inherited this system. Like none of them were involved in creating it. So like that's part of the dysfunction, right?
Yeah. So our visits start prenatally. So these, they will have a consult with us around the third trimester. And it is a change in mentality. It is a change. It's like, wait, you're going to come to my house? Wait, what's going on here? And so we have to kind of really do explain the benefits of that as well. And then thereafter, we go to their first appointment right after usually most of my patients are, and we can talk about how I work with the midwifery because it's a little bit different because here in Colorado, midwives are up to 6 weeks that they can provide care. And then we actually, in most of these people who do midwifery care also want a pediatrician. So we kind of align with what the midwifery group is going to be giving. And it changes per midwife group as well. So we kind of customize care that way so that dyad is getting support throughout these 6 weeks essentially, and even more sometimes. But typically speaking, if you think about a hospital setting, come home, the pediatric appointment is done about 24 to 48 hours after they've come home. That appointment lasts about 60 to 75 minutes. So it is a very longer appointment just on that face value. And we do complete newborn care that's already done, literally bringing the clinic to the home. And then from the maternal end point of it, we are looking at maternal vitals. We are looking at how this person is recovering. We have space to talk about the birth. We have space to talk about address any birth traumas that is there. Then we talk about safe sleep, and then we talk about, now most of them, they have their partners there, and talk about what is objective roles of the partners, because most people want to help, and the thing is people just don't realize how to help, right? And it's like, okay, well, these are some concrete ways that you don't have to just change the diaper. I want you to sunbathe and do some skin to skin because this is going to help jaundice. And hey, mom, you need to, when they're doing this is mom and dad time, or baby and dad time, you cannot interfere with that. And that kind of overlays into like long-term stuff, right? So then those moms from the get-go are allowed to be like, okay, I don't have to be the primary everything for this child. And I start trusting my partner into being like, okay, they're going to keep him alive for 15 to 20 minutes. And I saw that a lot with my own career, because it was just like, you are taught that from the get-go, you're everything, right? Like you're the only one that knows the answers, and you can't rely on the community that you're building. And the community is your partner. And so just allowing that person to be like, no, 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 we're going to step away, and it's okay for you to step away. It's okay for you to recharge. And we talk about prolactin levels. And you're like, prolactin levels are really low in the afternoons. The first 2 weeks, I really don't encourage the nighttime. Like I'm sleeping during the night, and then my partner or my husband or who fill in the blank is going to be bottle feeding, because it doesn't align with what's going on in their bodies. And like you point this out, it's like, your prolactin levels are really low in the afternoon. I bet you feel really tired then. And they're like, oh yeah. It's like, well, then that's the time where you need to take your naps. That's the time when you need to be like, okay, I need a break. And so all this education gets there. And then in this 2 weeks, and we come back at 2 weeks, and during this time they have direct access to me, because one of the things I felt also going through the system was like, you call the nurse line about something small, right? Something small.
Mm-hmm.
For you, it's huge, because it's particularly if it's your first newborn. But I've seen with repeat families too, like simple things as a duct being clogged, like a nasolacrimal duct, like, oh, I just want to make sure that it's okay. But when you're sitting there and you have 4 to 6 hours as a response time, you Dr. Google it, and everything is like wrong in the world, and you're doing absolutely terrible things. So our response time is at most an hour. I say that just because I tell them, that's like, do you see me doing it here? But most averagely is 10 minutes. And, just for them to be like, I mean, I get tons of poopy diaper pictures. I get tons of like eye pictures. So that part is, and then in 2 weeks, we talk about, other stuff. We're talking about, again, mental health and how they're transitioning. So remember, like, if you get the support, so I'll tell you what the data that we've found personally, but if you get the support that you need, you don't have to have mental health issues. I just had a client in September, just said, I am actually doing really well. Is it okay for me to feel this good in my postpartum? And it really shocked me, because we've created a world now where we can't just enjoy and be guilty about enjoying this time period with our newborn. And she was really questioning that, am I supposed to get mental health issues? I'm doing really well. Is this okay? And that like struck me to be like, how far have we come?
Crazy. Isn't it? The cultural experience of lack of support is so normalized that when you have it, you don't even know how to contextualize it. I had a Clay like that once. I checked in and I was like, hi, we just need to do a quick screen about postpartum depression. How are you feeling? How are your emotions? And she was like, I have postpartum elation. What's
Yes.
depression? You
Yes.
guys come and check on me every other day. Like, people are feeding me. I feel so great, you know? So yeah, I love that is happening for some of our clients. And at the same time, it does make me so sad for the general population that is thinking that, like, this is another pet peeve of mine, is actually when people talk about postpartum depression, they shorten it and they just call it postpartum. And I'm like, oh, what word medicine are we doing there? Like, oh, she has postpartum. Like, no. Let's not call it that shortened phrase, because then it starts to have this bleeding meaning across everything, you know?
Exactly.
Anyway,
Exactly.
yeah.
Yeah. And then we kind of rounded off at like the 1 month, and we're doing the official screening, and we are using our Edinburgh and GAD anxiety scales. And then we're very importantly talking about pelvic physical therapy. And we have a pelvic physical therapist on us on our team. And she's provided amazing education, because some people just don't realize what their pelvis has gone through, and really kind of negating this idea that it's normal to leak. It's normal to have some degree of incontinence, because our grandparents said that, or our mothers, or pain, the sexual pain. And then underlining all of this is, again, going back to, the partnership of what got you there. Because I always say that, hey, listen, this is a partnership that got you here, and how to slowly build up on that. So, for example, the first thing that I talked to you guys about is like, no, you're going to be doing the sunbathing and the skin to skin. And then we start with adding coffee dates. I never do lunch and I never do dinner, because it's just very, I just remember being in that space, and I was like, well, what, you're asking me to leave my child that I've been carrying for 10 months in my belly, and you're asking me to go have dinner? It was like, it was just there. So just coffee dates, and just kind of starting to set those things into motion, to be like, okay, we're going to start with the coffee date. We're going to go back to being friends. This is a really hard time for both of you in your relationship as well, but we're going to start as friends, and then we're going to build up to the fact that, at whatever point you want to have sexual relationships again, what does that look like? It doesn't look like at 6 weeks you get the green light and you're like, woohoo, way to go, like, we're going to go do this, because it might not be right for you at that time. However, you can just sit there and cuddle each other, and that's okay. That's okay for that time period. So there's a lot of those things that actually happen. And
that's beautiful.
lastly, because it doesn't happen in a vacuum. Because what I want my mothers, at the end, what I want my mothers, when they go through our program, is to feel empowered in the medical system to speak up. So at the 6-week appointment, we give them a list of questions that they need to ask, to make sure that they're in tune with their body, and to make sure that they know that, okay, this is what their body is at this point. And then I want them to realize about their relationship, and about how parenting, it really, you're going to breastfeed for a short amount of time that you're going to parent this child. And sometimes coming into parenting, what that looks like, especially in times of stress, so in survival mode.
I just love it. It's so holistic, and it's so extensive. It feels like it's reminding me of the Gottman lab, the Gottman research. Did you ever come across that research? This was a husband-wife team who studied couples before, during, and after pregnancy, and before, during, after divorce. And they're these kind of relationship experts. And they kind of famously said, like, having a child before you have it versus after you have it is kind of like the difference between watching a tornado on TV and then having one actually rip the roof off your house.
Yeah.
Like, you can't, there's just this massive transformation, this massive reality check that happens in that parenting transition. And we're so unprepared for it in our culture. I love what you're doing to help prepare for it. It's really so inspiring.
Oh,
I imagine that. Yeah. Well, it's so inspiring because you're really breaking the mold. And I feel like it's really brave. I mean, a lot of midwives will listen and be like, yeah, we all do that. But for you to have gone from mainstream medical education to all the way to this holistic place where you live now, it's really brave. It's really courageous. I'm really super impressed. And you've done it with facts and figures, and you've done it with like structure, and you've created this whole movement, really. And I wonder two things. I wonder, first of all, if you could tell us a story about how this care has caught some things that would have been very scary if they weren't in your care, because I'm sure that's happened for you. It's not all puppies and sunshine, right? There's a few situations where that in-home medical care made all the difference. I'd love to hear that. And then I want you to tell us how you pay for this. So that's my next question.
Oh, sure. So going back to, let's talk about mental health, and then we'll talk about something very physical. So mental health, we've done about 350, 60 dyads. And so that's the birthing, person, mother, newborn group. I've only told one person to start on postpartum medications for postpartum depression. Her husband was, he had to go back and activated on duty. And she had 2 other kiddos, and it's like, you need this. Like, that's the only time I've said that. Yeah, 10 to 20% of women do come on some sort of SSRIs, but their main concerns is that this is going to be harmful to my child. So there's a lot of education behind that. It's a lot of like, okay, like if you ever are worried about any of these things, then here's some of the resources. And then for the majority of them, it really is a space to be heard. And I've had a couple of moms say, and we will take extra time, and we will be like, okay, now you are, I remember this particular mom, husband had to go back to work. She has an older 2-year-old and then this newborn. She was feeling good, and she was just like, okay, so we actually made very concrete plans with her. It's like, all right, she goes, I want to go out, but I feel overwhelmed. Okay, go sit on your porch. It's okay to go in the backyard and sit on your porch, and giving them concrete permission things for them to be like, a month later, she's like, oh, I actually came to the Denver Zoo and I'm doing well. But it's really that type of stuff that women need. It's like, okay, I know what my end point is. I just don't know how to get there. And sometimes it's like, no,
step
10
by
minutes
step.
outside, step by step. And sometimes you are in survival mode. So sometimes you just don't know what the steps are, what to take.
Right.
Right. Just like you go to a personal trainer, right? You know what your end goals are. And you're okay, but how do I get there? Then really what really changed, and this one we have saved a woman's life for, she was suicidal. She called her, so we do work with the OBGYNs because I am not OB trained. She couldn't get her mental health therapist until a week after. And we all know, working the postpartum period, like every day, sometimes every hour counts. Olivia, our therapist, was able to talk to her within an hour. I was able to talk to her too. We kind of made a plan with the family, and I know, and she's also confessed it, that we saved her life because of the timely medical treatment that we were able to provide for her, and the bridging that we were able to do for her. And then lastly, going back to maternal mortality, is when we look at the data, when we say medical implications with it, is I had a woman, her name is Sarah, and this is about 3 years ago, and this has kind of really opened the doors to maternal mortality and really kind of changed the whole trajectory of. So I actually opened Naya Care because I suffer from postpartum depression, and I was like, I don't want any other mom to suffer from postpartum depression. And then this 3 years ago, we totally did a 180 and added maternal mortality, and that's like my platform. She had hired me because her neighbor was successfully breastfeeding. She didn't have a good relationship with her first baby, who was now 4, and she's like, you know what, I want breastfeeding. Okay, great, let's go to breastfeeding. This was over Labor Day weekend, and so I saw the baby on Friday, and we kind of did a couple of things with breastfeeding. But what was notable was the mom was complaining about neck pain, and she was barely able to kind of just get up and walk, and she goes, it's just really bad neck pain. And so I was like, okay, well, let's talk to your OB. And this is the time I wasn't doing vitals at all. And I was like, okay, because I didn't realize the immensity of it at that time. Because I'm a pediatrician, right? Like I was like, oh, I'm doing all your maternal mental health and all that kind of support. So I was like, okay, let's talk to your OB. This is Labor Day weekend. I'll come back on Tuesday. I've got to check on mom. I got to check on their baby. Anyways, we'll talk more and stuff like that. Come back on Tuesday, did my appointment, was leaving. And she goes, hey, Dr. Patel, can I need a primary care physician. And I was like, when do you need a primary care physician? Side note, my mom's an OBGYN. So I've been underneath that world and with my mom, and just like, the old days that you have the beepers and my mom would be on the phone talking. So you get exposed to a lot of the OBGYN postpartum part of it.
Totally.
Why do you need a primary care? They're like, well, they gave me a muscle relaxant over the weekend and it hasn't helped. And my OB has said that, hey, listen, we can't do anything more about it. But I'm like, but you're 9 days postpartum. This is still an OB issue. Like, why do you need a primary care physician for that? First time, I was like, let me just check your blood pressure. I didn't believe myself because I know old-fashioned blood pressure machine. It was 180 over 110. And I was like, you know what? I was like, listen, I don't believe my machine because I didn't trust myself. Because I was just like, why didn't I trust myself? Right? Because when something goes so awry, you're just like, you look at it, you're like, that can't be right. You're just like,
well, and you're also in a new space a little bit. So like, yeah, I think self-questioning is real there. Yeah, I totally.
I was like, let's go get one from Walgreens. And I was like, if you don't mind, can I run your case by my mom? She's an OBGYN. She practices in Nebraska. Can I just run it by my mom? And my mom was floored. She's like, this is still postpartum. Like, this is still post-op day 9. She was contemplating to going to a chiropractor that day. We got the blood pressure. The OB went to the ER. She had her vertebral artery, where the main artery that provides your head and neck muscles, it had dissected, meaning it had torn. And now she's on stroke watch. Like, it went from, now she's on stroke watch. So now I come back to this place. How am I going to tell her to breastfeed? I'm not going to put that pressure on her. She has a 4-year-old. She has a 9-day-old. She's put on stroke watch because this huge artery that supplies your head and neck is about to burst. So that's what I'm saying. Things just don't happen in a vacuum. And we undermine all of this. So based on her, we're doing vitals for every mom. We have had some near misses. We've noticed trends in blood pressures. We actually, this year, we got funded to do a study to literally just look at postpartum vitals, because there's not enough data out there. And most of the data that is presented, most of the data comes from the UK. However, there's no diversity in that data. So most of them are Caucasian women that are being looked at just because of their population, right? And so we kind of just gone through it in that way. And that's why when you come back to maternal mortality data and you look at it, you need medical interventions there.
Definitely.
I mean,
this is the hill that I think midwives feel like dying on too. It's like this holistic continuity of care through the entire process is the solution to the maternal health crisis. I'm, like same language, which makes me think, Sonal, you don't need obstetric training. Why don't you become a midwife?
What now?
Yeah.
Oh,
you could do it part-time on the side and have all this experience and be a primary care provider without the surgery, which you don't really want or need in the home space. So you're perfectly positioned.
I never thought of that. I never really thought of that. Okay, well, thanks for putting the little nugget in my brain. I will look into it.
Well, I know lots of people in your community. So if you want a preceptor, let me know. I'll hook you up.
Well,
well, either way though, what you're doing is like, it's so exciting. And I want to share something with you and with our audience is Midwifery Wisdom Collective and the Midwifery Wisdom Foundation that publishes this podcast is concerned with the community-based space, where we are an advocacy, education, and support organization for community-based birth and the space on either side of that. So that includes community-based providers. And so while many other advocacy organizations or schools or oversight or even government, NGO, different organizations focus on provider types. We have advocacy for OBs and for DOs and for CNMs and CPMs. We have just eliminated the pathways and the silos of education. And we said, look, the real difference is where you're practicing. Because when you practice in the hospital, there's a set of protocols and policies and expectations. And when you practice in the community, there's a set of protocols, policies, and expectations. Like, we don't do surgery in people's homes. That's not happening, right? So it has much less to do with provider type and much more to do with location. And so the Midwifery Wisdom Collective and Foundation is focused on all provider types, regardless of how they found their way to the community-based space. And so, of course, that's why we're really interested in having you be keynote. That's why I love talking to you today, is because you found your way to community-based space. And that's what we celebrate and champion, is whether you call it that or not, you are practicing the midwifery model of care, because the midwifery model of care is in the community space and the obstetric model of care is in the hospital space. And even hospital-based midwives who practice in the hospital are frequently using the obstetrical model of care. Whereas even when physicians work in the community-based space, they're using the midwifery model of care. And so that's our champion. That's what we get behind. And, obviously why I'm so excited to talk to you and to celebrate you is that you're in this space. And my question, or kind of my follow-up from this, is how do we get more providers in mainstream to come into this space? What is your success? What kind of conversations are you having? Who's joining this mission with you? How do we get successful with this?
Yeah, so we actually have created, there's about 10 or 15 physicians around the United States that are doing similar kind of home-based work. And so we've created a national nonprofit called Center for Fourth Trimester Care, where we're bringing all the voices. It's physician-led, but we're bringing those voices into that space. So again, it's OBGYNs, PMR doctors who deal with, the aftermath of birth trauma, anesthesiologists, pediatricians, family practice doctors. All of those people are coming into this space and saying, okay, we are under this umbrella and we really want to change fourth trimester care. This is what's happening, is that you have silos of organizations. You have the AAP, American Pediatrics, over here. You have OBGYNs over here. Family medicine is a really good model.
Neonatologists, nurses, all of it separate. Yeah.
Exactly. Yeah. All of it separate. When we aren't, and we are basically, it's a big elephant and we're all looking at from one side to another, as opposed to setting back and saying, okay, this is what the data is showing. This is where medical care needs to change. And all I'm talking about is the medical care, because that's the only lens that I have in that space, right? How can I change the medical system in which majority of the women are exposed to and which majority of the women choose, because sometimes they don't even realize they have choices. And that's a whole nother topic and a whole nother education thing. So, but how do you look at this system that we already have in place and really push it to change it and push it from the get-go? ACOG has come out and said that, they've defined high risk and stratified high risk patients that have blood pressure issues and when to see them at 2 weeks, at 4 weeks, and all of that stuff. But again, my biggest gripe is, but you're missing out on what that person has gone through. You are undermining that. Look, just come to me for the blood pressure. Really exciting stuff that's happening is telemedicine with blood pressure issues. Great. So now you're not forcing that woman to come in. And then looking from the pediatric lens is no, I don't need to see your baby. I don't need to see your baby every 2 days, because objectively I'm just looking at a number, but I forgot to ask you if you got tons of IV fluids. And now I'm just following a number rather than following breastfeeding and rather than following all the other objective markers that tell me that breastfeeding is going well. So really kind of changing that narrative, that push to be medical home visits. We're partnering up with 2 pediatric offices where we're going to be providing the first post-discharge hospital visit to the house. So it's making small changes like that and saying, okay, no, we're going to provide this at the house. And then at 2 weeks, you have the choice either continuing with us or you're going to go back to your pediatricians. But it's literally taking
Cool.
them with small steps, right? It's saying, come with me. Like, I'm telling you, this is better,
Yeah.
and stuff like that. So yes. So Center for Post
Well,
Trimester
so
Care.
the nonprofit, yep. Go ahead.
Anybody can be a member. It is a physician-led group, where our board is consistent of the variety of physicians that I've mentioned, and but anybody can be a member. It's $50 for students for the first year and $100 for anyone else. And then we do have conferences. We're going to have a joint conference with doulas here in September. So that's going to be really exciting as well too.
That is exciting. Well, we'll link that in the show notes. Well, so you've created this nonprofit. We're doing lots of education. You're obviously doing tons of outreach. Now there's more than just you, right? You have other physicians that are involved in this process, right?
Yes. Not that many though. Enough to kind of,
yeah.
yes. And
well,
it's hard.
Well, I would say, I think that midwives are a natural, partner in this process and this work. And so, I would say, there's about, probably about 10,000 midwives across the United States. And at least 4,000 are doing regular, frequent postpartum home visits as part of their normal standardized care. And so since they already have the system and the process, it would make sense to involve them in this process. So I'd love to connect you with some change makers who are in this place, because what you're doing is so important, but there's no need to reinvent the wheel, right? Like there's so much of this that exists strategically and long-term and traditionally, and it would just be cool to, again, create more clout, more public awareness, so that not even public, more private awareness within the physicians, within, the entire post, like it's like the birth workers now encompass like 15, 16 specialties, right? And like this is the real like brokenness of the American Medical Association medical system, the medical industrial complex is breaking apart all of these specialties instead of recognizing that we need to see the mother baby dyad as like a one unit, and that we need to see the postpartum period as like the fourth trimester, like you call it. So it's just so exciting what you're doing.
So I actually wrote a book. It's called The Doctor in Her Black Bag, because I am one of those people that I need to understand how we got to where we are at. So check it out. It's on Amazon, on our website. Please check it out.
The thing was, which was so,
yeah. So historically, and this is going to lead into what you were saying with the advocacy of the midwifery system. So the turn of the century, when we had the industrialized revolution, and this was after the Civil War, and we brought more people into urban settings, what was happening simultaneously was that the hospital system we were relying on germ theories. We were able to reduce infections. And so that's a turn of when the hospitals started becoming more of a primary area for birthing. And so that was a huge shift with birthing that had happened. And then in the book, I explore this. I'm not going to go through all of it, but we explore the feminist movement. We explore the germ theory. We explore insurance, the role of insurance, of how it changed birthing and how it led to where we are right now. In the midst of this, what happened was midwifery kind of took a back end to it, or just took a back end, which was it was a very big disservice, because the feminist movement did do some positive things, but also it was a very disservice to the birthing experience of it. And then what is happening now is that every state has its own regulation. So as a midwifery system and as a midwifery person, there is not mobility. There is not a financial mobility, physical mobility. Colorado versus Florida is two different laws that are overseeing it. In some states,
sister,
it's like
preach.
Preach. I mean, in some states you can get.
I love that you know this. Yeah.
Yeah, and because the data just shows it. In some states, you can actually go to jail for having a home birth, and sometimes home births
Yep.
don't happen. Like they happen accidentally sometimes. I was actually a prime example of that. I could have had a home birth accidentally. And so when we need to change the medical system, midwifery, we need to go back to it in a way that is the policymakers and they understand it. So what happens
Yes.
in advocacy and policymaking is that someone gets the ear of a legislator and they just run with it. But sometimes what they have
Yeah.
been told is not correct, where it could be a short-term solution, but long-term solution, it really is curtails the mobility of a system to go. So going back to the data and maternal mortality, when you do look at other countries that have maternal mortality rates that are super low, such as the UK, such as Japan, where their rates
Netherlands.
are
Yep. New
Nether
Zealand. Yep.
the
They have midwives
women's
are a part of their care. Absolutely. Yep.
no,
Mhm.
women's health. So I'm going to even take it one step further. Women's health starts with midwifery care. That's where women's
Yeah.
health starts with.
Yeah.
Then
Love
your
it. Mhm.
OBGYN comes in when there are issues. So there's a
Right.
stratification of it, right? That's when it comes in.
Yep.
And one thing the UK system does really impressively well, because what happened at the turn of the century too, and I mean 19th century, the 20th century, the UK had about the same maternal mortality rates as the United States. But what they did different was they blamed the system for maternal death, not not the not the mom.
Provider
So
type.
I get
Hmm.
right. I mean, but not the mom. So look at this postpartum psychosis. This is my burning thing. What do we do with those moms? At the end of the day, we incarcerate them, but we fail to
Oof.
see how our system led them to that. And then we incarcerate them. And so now we're telling a woman who's going through this is like, you know what? If you feel this way and you have psychosis, you're going to be
Yeah.
imprisoned at the end of the day.
Yeah.
You sit there and
Yeah.
you're boggled. And I mean, you're just boggled to be like, anything that goes wrong, we're imprisoning women.
Mm.
And you're just
Mm.
like, that doesn't make sense.
Mm.
So that's what I'm saying. Yes, advocacy is just so important, but the right type of advocacy, the right type of legislation that has long-term effects, not the short, acute solutions and bandages, like I would just say they're just
Yeah.
bandages. And you're not like fixing anything. You're just saying, oh, okay, we're gonna fix it for this particular community. Okay, I'm gonna tell you one more thing
Yeah.
and then I'll
No,
like for
tell me.
example, when we look at maternal mortality data, we know overall when we look at there's discrepancies between our Caucasian mothers and our African American mothers and our Hispanic mothers. There is huge discrepancy of it when you look at a national level. However, when you look per state, for particularly states like Arkansas, your Caucasian mothers and your African American mothers have the same rate of maternal mortality death. And you look at
Mm.
that and say, well, that means that regardless of what system, the system is not working. Like we need universal solutions to a universal problem. Like we can't just be like, well, for
Mm.
this particular area is not working. But then when you go look at Georgia, and so California is one of the best rates of maternal mortality in our United States. They actually are comparable to our European countries. So what they have done differently is that they have universally standardized some care that it's universal. So
Mhm.
it doesn't matter
Mhm.
what race you are. It doesn't matter if you have your first baby, your second baby, your third baby, because pregnancy is a challenge with every birth is a challenge. So those are the
Mhm.
solutions that we need. Those are the solutions that we need to advocate for. It's like, no, we're not just gonna do it for this one particular group because it does, and that's the whole thing, right? Like all these home visitations, most of them are striated to you have to be low income or a first child, and you're like, well, no, you can have issues with your second child, you can have issues with your third child. Birthing is every time you go through pregnancy, it is a disease on a woman. Like I mean, just like it is.
Mhm.
And when we stigmatize health, that's when we see the discrepancy in data. So,
Mhm. Mhm.
but
Well,
That's a
Sonal,
lot,
tell us
right?
how are you funding this project? How are you funding this project? Because this is the main problem that midwifery profession faces is there is not direct and appropriate reimbursement from Medicaid, from private payer sources. Yeah, how are you funding this?
So I face the same challenges that you have just kind of outlined. I do take Medicaid, but we do it from the business end of it. There's different ways where we can benefit from taking Medicaid patients. They don't reimburse well at all. But again, for me, it was this has to be universal. Like it has to be a universal kind of solution. Like I'm not going to be like, no, you don't have it. Try taking private pay. Again, there's too much red tape there. And so I just don't deal with private pay. We take the HSA account, the health spending account. If you have an FSA, we do that. And now when we are through the Center for Fourth Trimester Care, where we're doing this blood pressure project, we have raised money that my type of care could be an opt-in option for those families that are going to be part of our blood pressures. So there's just kind of unique and different ways that we figure out how to fund care, you know, payment plans, sliding scales, whatever is needed. So, and anyone who knocks on my door and says, hey, I want this type of care, that's a win for me. And let's kind of quickly let's
I'm
figure out a
laughing because
way.
you're already practicing midwifery, Sonal. You just need to make it official. You just need to be like, I am going to join the poor and dedicated midwives of the nation to work for my soul's purpose. I love
and
it.
then yeah, and then you just keep knocking on those doors. And like right now, the state does have money, and they just sometimes just don't know where to give it. And they do
Mhm.
pilot programs. I've had two collectives, local collectives, come to me, and they're writing me in their grant. So that's another
Oh, are
way
you
that
working with
we're
Elephant Circle?
doing them. So no, I'm not working with Elephant Circle. I actually worked with them last year when we did legislation, because I'm a big advocate legislation person. So we actually, both them and my company, supported better care for incarcerated pregnant women, postpartum care and that. So that was a lot of fun to work with them. This one is Family Forward. It is an African American Black mothers, and then there's another one that is one is Our Tribe, which is a doula group, but then there's what's Birdie's one? Gotta keep forgetting. Mama Bird. So Mama Bird is another doula based group. So one is Family Forwards and one is the doula based group. And then the other thing is that the other hat I wear is I am the medical director for Family Connects program. Family Connects, if anyone's familiar, it comes from North Carolina. And it is, again, it's a universal program, 3 weeks. They provide a nurse who has some sort of lactation training that will go to the house at 3 weeks of that birth to help kind of assess what's going on with the mom, the baby, the family, and then one step they connect them to the resources in the community. It can be as simple as, I need to find a mom group to, oh, you know what, you really are a refugee. We can get you into get expedited emergency Medicaid for you. So the range is huge. And that program started with here in Colorado last October. And again, we're kind of expanding, and that's the things I see too. It's just like I see again, it is a home visitation program. It is not a medical program, but through those visits, through my nurses' visits, you see the issues. Like, so for example, we're talking about postpartum psychosis. One of the moms was released in postpartum psychosis. She was hospitalized and then released, and one of our nurses went to go see her around 4 weeks after birth. And she was having side effects from the medication, but no one checked on her. Like, she was barely able to walk. And you're just like, well, and then we're calling, and I'm using my doctor card and calling and, saying, hey, we need you to really. And so they changed the medication around because she wasn't barely able to walk. We had another mom who was complaining about pain and her blood pressures were so high. And you're just like, but when can you see your OBGYN? Oh, no, it's not another till 6 weeks. And so you see all of that too. So you see where, again, another way of the system is breaking down for these moms. And then you go back to be like, no, medical, we need medical care at this point. So.
Yeah, and the only distinction I make is clinical, right? Because it's not always medical. It could be nursing, could be midwifery, but the clinical attention to detail, right? That's the big thing that is missing when we talk about, you know, community support, doula support, like it's more than just psychological, and that well, it's more than just go ahead, interrupt.
No, like for example, like if you took a blood pressure, you guys as midwives, you're trained to do with that blood pressure, right? But if a nurse who is just, I mean, not just, but a doula takes a blood pressure, a nurse takes a blood pressure, there's extra steps that
but yeah, well, I mean, and this goes.
But you get what I'm saying, right?
I do. There's a distinction there, and this is actually a really a question I have that's kind of peculiar for me. Is I'm wondering, so in advocating for the community-based space, which we're both occupying, one of the things is we kind of make this distinction around one of the main jobs of a community-based provider is risk assessment. So we're doing all of these screenings, right? Both clinical, psychological, familial, environmental. We're like screening to say, are you high risk, low risk, or moderate risk? Like, where do you belong? And then if we determine that someone is high risk, we're going to refer them out, right? Because they don't belong in the community space anymore. They belong in the hospital. And I think this is this fundamental difference of what you're advocating for is so powerful, because what you're essentially saying by your work is you are low risk unless proven otherwise. You belong in the community unless proven otherwise. And that's like the complete opposite of what the mainstream world is saying. That's what would really change things for us, is if we did this proper risk assessment, assuming that you're, not guilty, you're low risk unless proven otherwise. And then the providers who do those assessments can then make the referrals to the specialists that exist in the system as needed. Is that also how you perceive your process, your role?
Oh, definitely. I mean, even going back to you guys as midwives, since I work with so many diverse midwifery practices here, from the birth center to the home births and everything, because of the training that you have gone, you know when to stratify that risk. It's like embedded in you guys,
Right.
You know how to easily stratify that, versus if you have, at the 3-week, a nurse coming in from just a community nurse, they might not have that embedded training to be like, they might have like little pricklies, depending on how much they've worked in the community. The thing is, your training has prepped you for that.
Yeah, risk assessment is at the foundation of our care. Yeah. Mm-hmm.
Or is this the right amount, or do you need to actually go into the thing? And then the care doesn't, it doesn't, there's not a lack of timing of care, because we all know in the postpartum world, the timing of care is so important. And maternal mortality data is showing us that over and over again, and we're just kind of ignoring it.
I think we're natural allies. I want to find out how much more we can work together. And I would love to see, I don't know. I'm so excited to see what's coming, what you're able to do, because you've already been able to do so much. And I think there's so much more that can be done in this space. And it's exciting. It's exciting to be centering the moms, centering those parents that need that care so much. And to have, I mean, you said I'm using my doctor card, and there's a bit of that's how rigged the system is, but also thank you.
Yes.
I want to say thank you for pulling out that, 8 to 15 years of education and money to be able to wave it around and be the advocate that parents need. You're advocating in in one of the most overlooked areas of health. And just thank you. That's what I want to say. Thank you very
Yeah.
much.
Oh, yes. No, thank you so much. I mean, like you said, I guess I'm going to go be a midwife now and put that.
I think so. I think you should. Like, I'm serious. If you're really serious, I'm serious. You message me and I'll hook you up. I've got some great preceptors in your state.
Okay.
It's a very quick process. 2 years, Sonal. 2 years.
All right. Let me percolate on that a little bit. So
okay.
Yeah, no, I mean, just the last,
well,
I know
was awesome.
Yeah.
So much. Yeah.
No, it's like I think you're absolutely right. We're definitely great allies. And I think in one area that we can really kind of come together with both our voices as our Center for Fourth Trimester Care and the Midwifery Wisdom Collective is through advocacy and legislation and looking at, policies that are being presented and saying, okay, well, this is a great policy. These are all the positives of it, but you're missing out this aspect of it because we're both coming from a place that we've seen a lot and we know on a granular level what works and what doesn't. And I'm tired of putting bandages on. Like, just really quickly, like that whole postpartum drug that came out, and I wrote an article on it. It's like, it's just putting a Band-Aid on it because you're overlooking the root, and we can't stop. We have to stop putting bandages on our problems. Otherwise, it's never going to.
Well, I mean, that's basically, that sums up the medical industrial complex, right? I mean, it is all about medication and covering up. Well, we posted a blog post about it too. And the list of side effects is like worse than the actual original issue. It's mind numbing to think that this is gonna, and anyway. Yeah, whole nother podcast. We'll put a pin in that one. Well, Sonal, thank you so much for making time for us early in your morning and to chat with us here on the podcast. So grateful. Where can people find you online if they want to follow you?
Just actually NayaCare, NayaCare, and we are across TikTok, Instagram, Facebook. Just
awesome. All the things.
Way. Yeah.
All the things. Well, take good care of yourself. Thank you so much. And we will be in touch.
Thank you.
Thank you.